So I'm going to come into the room and I'm going to introduce myself to the patient. My name's Jim. I'm your student nurse today, and it's time to do your morning assessment.
What is that?
Well, that's where I have to check you over and write down how all your body systems are doing. So what I'm going to do now is I'm going to check, like I said, once again, check the wristband, make sure it's the right patient. I have to check orientation. So I'm going to say, now I have to ask you the 3 questions we ask you every day. What's your name?
I don't know.
Well, then I'm going to have to say she failed the person part. Do you know where you're at?
No.
So
I'm home.
no, you're at Ivy Tech Sim Lab, room 3. We're getting ready to simulate doing your assessment. So failed person, failed place. Do you know what year it is?
Well, it was President Roosevelt.
Okay, well there you go. So we failed person, place, and time. Generally, I've found over the years that the first thing to go is time, second thing to go is place, and the last thing is person. So if they fail person, they're probably going to fail the others. But you always ask, because I have had people that are, disoriented to place, but not time and person. So you just never know. But generally, they're going to go in that order, in my personal experience. So this person is
Can I go to the bathroom?
we will get you to the bathroom in just a moment.
Okay.
Now, normally we would go to the bathroom right now, but since that's not part of this checkoff, and this lady's just harassing me as our checkoff. But anyway, so first things first, we would do our toileting and AM care and stuff. Then I would do my assessment. So after we go to the bathroom, we are going to continue the assessment. So I'm going to raise the bed up because I'm a little taller than most people. I don't want her toes to get smashed by that over bed table. Alrighty, lower the bed rail, and I'm going to begin the assessment by looking at her hair. Now, I'm not going to tell her that I'm looking at her hair, but I am just going to look at her hair. I'm looking for nits or lice. I've seen people with bed bugs. That's pretty scary. But anyway, just look in there. I'm looking for dryness. There could also be maybe she fell in the night on night shift and nobody knew or told me about it. I'm looking for blood or wounds or knots or anything. Kind of like patient safety stuff. So there's nothing there. I'm going to look at her ears. Now, when I look at the ears, I'm looking for exudate or any type of injuries or just anything out of the ordinary. I would also just come over here and look at the other side. I could also take my light. Let's see here. And I could also kind of look in there with my pen light or light just to see if there's any drainage. And of course, drainage would be a sign of a potential infection, ear infection. So then I'm going to want to look at her eyes. Now, there's a thing called PERLA, pupils equal round, reactive to light and accommodation, PERLA. So you have to know one thing: what's accommodation? How do you measure the size of the pupil? Things you'll need to know. They might be asked on a test. So I'm going to say, now look at my nose, and I'm going to shine the light into her eye. Now sometimes this light might be messing me up because it makes her pupils constrict. Sometimes you want to turn the lights off a little bit or shade their eyes. And you're looking at, and they are both reactive and they are both equal. And then accommodation, just look at my little, okay. So pupils are equal reactive to light. Then we are going to continue on with the assessment. And I'm going to ask her to open your mouth and say ah. Ah. Stick out your tongue. Ah. Okay, there you go. So I'm looking for any lesions. I'm looking for coating of the tongue, thrush, but everything is pink, moist, normal. So we are going to move on with the assessment. I'm wanting to check the lymph nodes. And I'm looking for any type of swelling. You can also check the thyroid gland. Swallow. And you're looking for any swelling or nodules. Let your head back for me again. Swallow. Okay. So now we are also going to check the neck for movement, see if there's any range of motion problems, any stiffness, and it appears there's not. Now I'm generally letting her do the motion. I'm just kind of gently guiding her. Okay, lay on back. Now I'm going to move on to my heart sounds. Now we are doing assessment. As I said, this is a sim lab, so we're simulating an assessment. Now it's a lot easier for a woman to do assessments because men don't mind being shirts or skins in basketball. Women always want to be shirts. Let's just be honest here. Now, for a man, I could just pull this shirt off and just do the assessment, find the landmarks. You really can't do that for a woman when you're a man because they get offended and stuff. And that's just how it goes. So normally I would put my stethoscope in my ears, but I'm not going to do that because then I have trouble talking to you. So we'll just do this. What I'm going to do is, as I'm looking at her chest, I'm visualizing a two. You'll get a piece of paper for this, in class. But I'm looking at aortic, pulmonic, tricuspid, aortic or mitral, and between the tricuspid and the pulmonic is Erb's point. Now, when I am doing my assessment, I see a lot of people wanting to just put their stethoscope on. It's hard to hear through material, and it rattles and makes noises. So what I always do, I always just take it, put it inside the shirt, and then I kind of move around like this. Now there are ways you are supposed to check for placement, and you need to know the anatomical positions of these placements. Clavicle, and then the first and second second intercostals is where you put it. I have been doing this for 20 years. I know approximately where it's at. But anyway, you can palpate for your sites. And you have to know those because it might be on a test question. I hate for you to miss an easy one. So I'm going to listen to the aortic. And move over to the pulmonic. And notice how I'm moving my stethoscope. I'm not reaching my hand down in her shirt. Now I can visualize the sternum. I'm going to just push this on down to where the tricuspid is. And after I listen to the tricuspid, I'm going to pull up a little bit to Erb's point, and I'm going to kind of move around and listen a little bit to where the maximum point, maximum sound impulse is, and that's what Erb's point is. It's generally between the pulmonic and tricuspid. Then after that, I'm going to slide on down to the mitral. Now with the mitral, generally in the hospital, women are not wearing bras. In sim lab here, almost everybody is. So it's sometimes it's a little difficult to get in here. If you're in a clinic trying to listen to heart sounds, women will generally have on a bra. You may have to tuck up under the, if they have a metal rim on it, you may have to try to tuck up under that metal rim. So, but just know those spots, know where they're at, and know the anatomical positions to find them. Next are lung sounds. Now, it's best to listen to lung sounds on the back, but I work in intensive care. So my patients are ventilated. Sometimes they have central lines, arterial lines. Sometimes they're restrained. So a lot of times I can't listen to back because it's just too difficult. It's just not worth the kind of like danger to the patient. So I listen to the front. You listen to the front and the back on these people. Okay, so, and what I always like to say is when I press down, take a deep breath in and out, and then they know when to take a deep breath, and they're not wasting big breaths for nothing. Okay, so when I press down, take a big breath in and out. And I'm listening to the lung sounds. And a lot of times on women with really large breasts, you just can't hear over the breast tissue. So then I would just take this and listen to the side. Okay. Very good. So now I'm going to want to listen to the back. Now there is a systematic way that you listen to the back, and I would just have the patient big breath in and out. It's in your book. Look it up. I'm just putting my stethoscope on her back on these different spots. Now sometimes people might be in respiratory distress, and you're going to want to give them a break because just this many breaths is going to make them out of breath. So it just depends on your patient. Generally, people that are not in with severe respiratory problems are going to be able to do like 10 large breaths. So we have our lungs done, we have our heart done, head and neck. So see, I'm working my way down in a systematic approach so I don't forget anything. Now, if you do forget something, you simply say, "Oh, I forgot to do this. I'm going to do it now." And that's fine, as long as you don't say, "I'm done," and didn't do it. So now I'm going to listen to the abdomen. So sometimes what I'll do is if they're in with abdominal problems, I want to get my stethoscope directly on their skin. For the abdomen, a lot of times I'll just listen through the shirt. But if they're in for some type of abdominal problem, I'm going to make sure they're covered and then just pull this up so that I can get to their abdomen. And I'm going to start at the right lower quadrant and listen. Now, if I don't hear anything, I got to get my watch and listen for 5 minutes. And I can't say no bowel sounds until I've listened for 5 minutes to each quad. And I have listened for 20 minutes before and heard no bowel sounds in all 4 quads. And it was quite distressing. So, and the reason you start at the right lower is because that's the noisiest, because that's where the cecum, the area where the small intestine and large intestines hook in, and that's the one that has the most activity. In general, you're going to hear something, and you're going to hear a gurgle within just a few minutes. But that's why you need to be listening to the abdominal sounds of your relatives and your friends. You need to be practicing this on them so you can hear a lot of different stuff. But pretty much it all sounds the same. So we have abdominal sounds in all 4 quadrants. So now I'm going to want to do some palpation. And what you're doing when you're palpating, you're seeing if there's any areas of tenderness in the abdominal quadrants. And if there is, they will say, "Ow," and you will have to report that to the doctor. So everything's fine there. So I am continuing on with my survey, and I'm going to want to check capillary refill on the fingers. And there is good capillary refill, less than 3 seconds. I'm going to want her to squeeze my hands and see if, give me a squeeze. Okay. Now I'm going to want to check for some range of motion. Or are we doing range of motion with the assessment?
With the bath.
Oh, the bath? Okay.
Yeah.
Well, I guess we've already done that. So anyway, we have capillary refill. The hands are warm. I felt them. Normal color. Weak strength, though. So anyway, we're moving on down the line. So I'm going to check her feet. Now that's why when you come to the lab here, you've got to know, don't neglect your hygiene, and remember we're going to see your socks, so don't have gray socks on. You'll be sorry if you do. So I'm going to check capillary refill on the toes. We have good capillary refill, less than 3 seconds. I'm going to have her push down on my hands. Now pull up your feet up. Okay, good strength there. I can also say push against me. Okay, so we've checked. So good strength in the feet. I'm checking for edema. No edema. When you do check for edema, if they have it, there's a thing called pitting edema, and that's something you'll want to read about in your book, but no edema. So when you come to lab, be ready to take off your shoes and socks. I'm also going to want to move on. Oh, and I'm going to say, you know, I should have been checking for my pulses. So I'm going to check for pulses now. And we have good radial pulses. I'm going to check for the pulses in the feet. So we have what are called pedal pulses and the tibial pulses. Posterior tibialis. So I'm going to check the pedal pulses first. Notice how I cross my hands over. I just think that's easier. It gives me more palpating on the sensory parts of my fingers. So I'm going to check for pulses, and they are equal. Now I'm going to check the posterior tibialis. And notice how I just think that's the easiest way to get the most palpation. Now, if you don't feel a pulse, but you have capillary refill, you know there's circulation there. Like especially if there's a lot of edema, that's when a lot of times you will have to get a Doppler and Doppler their pulses. If you're going to have problems with pulses, it's probably going to be in the feet also. Generally, you're going to be able to palpate radial pulses. So we have that done. So I am going to ask the patient to sit up, and I'm going to check her back. I should have done this when I was doing my assessment with the lung sounds, but I'm just going to look at her back. People can't see their back, and a lot of times if they have a mole or something that's going bad, it's on their back and they don't know it. I'm also going to want to check when she's bending forward. I'm checking her spine and looking at to make sure it's straight and make sure her back is symmetrical and straight. If a person's having problems with scoliosis, which is usually women, one side might protrude more than the other, so it's not symmetrical, or their spine will even curve. So anyway, everything looks pretty good here, nothing to report. So lay on back. Now, this patient, if she could get up and walk, I might assess her gait, but she's on bed rest, so I'm not going to be assessing gait today. What I'm going to do is I'm going to lay you down flat, and I'm going to check you out. Now, people that are really confused, they won't be embarrassed about checking their genital area. Now, other people that are oriented, you're not going to be checking them because they're not going to let you. They'll say no, and people can refuse stuff even when they're in the hospital. Don't think that a person that's alert and oriented times 3 can't refuse any treatment at all. We've sent people home to die because they weren't going to get a toe taken that was necrotic, and they didn't want to get anything cut off, so they're going to go home to die. Well, they can refuse because they're alert and oriented times 3. Now, there are people that can't refuse. The confused can't refuse. The unconscious can't refuse. Children, less than, I think it's 18 or 16, minors can't refuse. What else? I'm thinking, anyway, I think that's all I could, if a court has deemed you incapable of making your own decisions, you can't confuse. But anyway, a confused person, especially with a Foley catheter, you're going to have to assess that catheter, and you're going to take the bed linens off, and you're going to make sure that catheter's not pulling, and you're just going to check them out. Now you're checking for a woman, you're checking for any swelling, drainage, redness. And for a man, you're just looking at the meatus, and you're looking for any redness or swelling at the meatus where the catheter goes in. And then I'm going to want her to turn over on her side. And I'm going to want to check her buttocks area. Now, when I'm looking at the skin, I'm looking also at the heels, at the coccyx, at the scapula. You can also check the elbow. Also, surprisingly, I've seen the back of the ear, decubitus ulcers, which are bed sores. And what it actually is, it's called pressure sores, and it's from a person just laying in one position too long. I've seen decubitus ulcers on the lip, where they had an ET tube taped too tight, on the nose, where an NG tube was taped too tight. You can get them anywhere. So, there you go. Everything looks good. I've done my complete visual survey of the skin, and I know this patient's okay. So, let's see. The assessment is actually one of the harder checkoffs, I think, because there's so many things. I can't think of anything that I've missed. If I have, hopefully it's only one thing, because I would have passed. So, lower the bed back down. I'm going to want to raise the head back up about where it was so the patient's going to be comfortable. I'm going to want to ensure that the call light's within reach. And I'm going to ask the patient, is there anything else you need?
No, I'm in the bathroom.
Okay, we'll go to the bathroom again. All right, I think we're done. And I'm going to wash my hands and leave the room after we go to the bathroom.